I did not get.
We're very excited today to have a special session on telehealth innovation. We have a great speaker lineup, and we are very glad that everyone is participating in the webinar today. We're just going to go through a little bit about South Florida HIMSS, and then I'll turn it over to our programs chair, Nicole Bramblett, and we'll get the program started. So South Florida HIMSS is comprised of nearly 2,000 members, and it ranges from Boca Raton, Jupiter, all the way south, really into the Keys. We couldn't be here today or do the things that we do for our membership and the chapter without our sponsors. We've placed their logos here, so we want to give praise and recognition for them. Again, we couldn't do this today without the sponsorship. If you're interested in joining the chapter, I advise you to go to our website, or you can reach out to myself or any of the South Florida HIMSS board members. We've had quite a few virtual webinars throughout the 2020-2021 chapter year, given the COVID outbreak and the pandemic. We continue to plan for more webinars, and hopefully we'll be able to meet in person soon. I advise you to and encourage you to look at our website, become a member. It's a nominal fee to become a member, and then you will be notified by email about the events that we're hosting. You can also follow us on the social media platforms. They're at the bottom of the screen to find out about information about the chapter and our chapter events. So without further ado, we'll kick off the program. I'm going to hand over things to Nicole Bramblett. We encourage you to ask questions in the chat and share your LinkedIn profiles. We want to make sure that you're networking and giving you that capability as well. So thank you again for joining us, and take it over, Nicole.
Definitely. Well, hello, everyone, and thank you so much for taking the time out of your workday for this exciting telehealth innovation webinar with industry-leading thought leaders. I am Nicole Bramblett. I am the Regional Client Relationship Manager for Scrivus, which is a medical scribe and non-clinical support staff company. And I'm also the program chair alongside Grant. Just a few housekeeping items. Please make sure you turn on your cameras and stay muted as the presenters are speaking. We will have time at the end of the webinar for a Q&A, and feel free to use the chat box option to put any questions that come to mind along as well. And also, this webinar will be recorded in case you need to jump off early for anything. Now, I would love to introduce the moderator for today. Bill Manzi is the Administrative Director of Telehealth Strategy for the Memorial Healthcare System and a past member of the Florida Governor Rick Scott's Telehealth Advisory Council. For Memorial, he blends the strategic vision, strong clinical and technical backgrounds, a profound understanding of finance and operations to be able to implement the technology that delivers and improves the healthcare experience. Bill?
Thank you, Nicole, and thank you everyone for joining us today during this webinar. I was notified a little earlier that we have 212 attendees, 212 and a half attendees on the webinar today. So thank you all for joining. Whether you're joining us today during your lunch break at work or while hiding in a quiet room, drinking a glass of wine as your kids are in virtual school, I believe you're really gonna find today's session valuable. As Nicole already mentioned, I'm Bill Manzi, and I'm the Administrative Director for Telehealth at Memorial Healthcare System. I've been involved with telehealth since around 2013, and I've had the opportunity to participate in the changes in telehealth over the years. As most of you know, and most likely is why we have all of you on the webinar today, due to COVID, 2020 saw a flurry of changes in regulations around telehealth and virtual care. But the truth is, it will be up to 2021 that determines our new healthcare reality. Today, we have 4 wonderful panelists that are going to share how they and their organizations have taken advantage of telehealth innovation. Please, as Nicole and Kendall have both said, if you have any questions that you would like to ask, since everyone is muted, just include them in the chat and we will be watching those and we'll pose any questions that there are in the chat towards the end of the session. So without further ado, buckle up because the ride's about to begin. Okay, so our first presenter is Sophia Batalas. I'm going to read a little bit about her in case you don't know. Sophia has over 25 years of experience working in large healthcare settings and in health IT consulting. She is an expert in nursing and physician workflow processes, EHR design and implementation. You go, girl. CMS regulatory reporting requirements, and known for building and developing highly effective teams. One of Sophia's biggest passions is the ability to effectively guide leaders and mentor new hires in looking at technology. So thank you for joining us, Sophia, and please take it away.
Thanks, William. Appreciate it. And thank you all for joining us. So I want to start out by saying, do you think telehealth is here to stay? I would say yes. Physicians and consumers are saying that in the short term and foreseeable future, they will be utilizing telehealth services. So a study conducted by Amwell, as you see on the slide, shows that such thing. And a resounding 92% of physicians have stated that they're going to continue to use telehealth services after the pandemic. Not sure if you believe me. Well, CMS actually provided some information letting us know that in regards to Medicare recipients, last year from March to October, 24.5 million beneficiaries utilized virtual care services. So we all know, I mean, you see there the quote from our former CMS administrator, telemedicine does not replace in-person care, but it certainly complements it. And it also provides powerful clinical tools that now are at the hands of our seniors that they can certainly decide as far as access and choice. But what does that mean from a legislation standpoint? Let's go to our next slide. I'm giving you a very high level overview of what this all means. And certainly the first thing that I like to say is you need good sources. So the Alliance for Connected Care has been a great source to be able to get updates in regards to legislation. Just from March to December of last year, there have been over 43 different bills that were introduced in relation to COVID, but also that had telehealth and remote patient monitoring provisions to them. The CARES Act, as you all know, provided COVID relief, but it also looked at expanding broadband access, and it also looked at providing $250 million to the FCC in order for them to start a telehealth pilot program. Want to know more? Well, the American Medical Association, what did they do? They worked on bipartisan legislation, and last year in July introduced what was known as the Telehealth Modernization Act of 2020. During that bill, what they had was making accessible telehealth services to patients in cities, rural areas, as well as allowing different types of practitioners to use telehealth services. And just last week, there was a bill that was reintroduced, bipartisan legislation again, in which they called it I'll have to read it, Protecting Access to Post-COVID-19 Telehealth Act of 2021. Say that 3 times fast. This bill actually has the provisions of eliminating geographic sites to allow the patient's home to be deemed as a distant site. They're looking at CMS having the authority to be able to provide reimbursement for telehealth services after the pandemic, 90 days after that, and also looking at putting some waivers as permanent waivers to allow HHS the authority to release those should there be future emergencies. And with this, they also want to look at having a study to show how telehealth services during the pandemic affected cost, rates, healthcare outcomes, and racial and geographic disparities. But that's not enough. What else is there? It was through the American Telehealth Association letter submitted to Congress that actually listed a lot of these items there. and it had over 339 organizations that signed on to that letter, of which we can say HIMSS was one of them. So that's quite a lot, but still not enough, because I actually read that there are over 300 nationwide bills that are promoting telehealth access. And no, I don't know all those bills, but certainly that is quite a lot. And when we look at the state as it pertains to legislation, a good source that I'd like to recommend is the Center for Connected Health Policy. This is one that actually looks at each state's telehealth laws and reimbursement policies. And you see a summary there on the slide in regards to the state of Florida and what they've come up with, but it also has other items in that report, such as substance abuse services and online prescribing. Another great source that I like to be able to tell everyone about is the Southeast Telehealth Resource Center, and it was through there that I actually found a House Bill 247 that was introduced 2 weeks ago that talks about the allowance of physicians to provide online prescribing for controlled substances for mental health services, as well as adding audio only as part of the definition to telehealth. And I don't want to be remiss in looking at the federal telehealth legislation, which is the physician fee schedule that you probably all saw at the end of last year, that had key provisions there in regards to telehealth, such as making finalized additions to some codes, adding a category 3 criteria to look at telehealth, some other new telehealth services, providing a waiver for the audio only evaluation and management code, and also giving a waiver to eliminate the restriction of established patients to allow for remote patient monitoring. And that's just a few of the items that I've been able to list for you in this very short time, and certainly reach out if you have any questions through the chat. But what I want to leave you with is, in our last slide, looking at what the National Law Review is thinking as far as health law predictions into 2021. 5 key areas that they very much are looking at. Licensing. As you know, through the PrEP Act, there were waivers that were put in place for our physicians to give them the ability to practice across state lines. And we certainly want to make it easier and reduce burden for them as they continue to do what they need to care for their patients. Modalities, this is a big area. You know, audio only has been a challenge in many states. And so this is going to be important. And the American Telehealth Association, actually, they published a what they call model language policy, which is looking at best practices. And those best practices are really deemed in trying to establish the right medical standards of care and quality services as it pertains to telehealth. Privacy. We all know very much we want to be able to share data, but how are you managing that data, and how's that coming across for your patients? We want to make sure that there are data privacy laws that protect our patients and consumers in the long run. And so how have you managed policies? What are you doing in regards to governing your data? Enforcement. Have you heard this week, $934 million virtual care fraud bust that happened where? Tampa, Florida. So what does that mean? OIG, DOJ, they're going to be putting in some standards for auditing. Are you ready to meet those audits? And last, payment. Definitely want to make sure that when we're looking at that, we're expanding services. And in a PricewaterhouseCoopers survey that was conducted by healthcare executives, what they stated was they're looking at mental health, psychiatry, family medicine, pediatrics, OB as the key services that will move into 2021. From our payer standpoint, we definitely see they're going to align in suit with CMS. When it comes to pharmaceutical and life sciences, I think it's time that they very much start to plug into telehealth services. There is quite a lot that they can move into that area. And finally, with providers, enhancing the consumer experience. I think it's very important to make sure that they're following that continuum of care, but need to be watchful that they don't, get themselves into some new disparities because of the lack of telehealth technology available to them. So I've given you a lot in a very, very short time. I certainly, like I said, through the chat, happy to answer your questions. Our next slide, I provided you some sources for you to be able to utilize, to look at for yourselves. But I will put into a chat a source that I wasn't able to get on here, which is the latest telehealth codes that CMS has published, so that you can have that. And certainly I'll also add a little bit more about who we are at EMIDS and what it is that we do to be able to help our payers, our providers meet digital transformation needs for their consumers. So thank you very much.
Thank you, Sophia, for all that information. I'm sure you're going to have a lot of questions towards the end of this presentation. Thank you. So without further ado, we're going to keep this moving. Our next speaker is Dr. Rari, and I'm sorry if I'm pronouncing that wrong, please correct me. She is director of the telehealth program at Cancer Treatment Centers of America. With over a decade of telehealth experience, she optimizes the delivery of healthcare by providing implementation strategies at the intersection between care delivery and digital technology. How important is that? Dr. Rari has a particular interest in utilizing telehealth to advance health equity by increasing access to top quality oncology care to rural and underserved populations. So thank you very much for joining us, and please take it away.
Great. Well, thank you. Thank you all for having me. I'm excited to be here today and to share with all of you what we're doing at CTCA and how we can, how we're truly leveraging telehealth to advance care in the oncology space. I will provide a bit of an overview of CTCA, a comprehensive cancer care network, for all of you all on the call. And then we can move into some of the clinical use cases that we're utilizing telehealth with, and moving into the hybrid model and extension into the home. Historically, before all the guardrails in essence were removed, telehealth has really been spotlighted for urgent care use, and perhaps in some primary care settings, but it's a specialty care where I find it particularly interesting, and I wanted to present how we're utilizing it in the oncology space. Strategies for economic sustainability in telehealth. So I am an endocrinologist by training, and I focus on endocrine oncology. At CTCA, we have a national footprint. We have 5 comprehensive cancer centers across the US, and our administrative headquarters are in Boca, so kind of in your backyard. We additionally have 10 outpatient cancer centers affiliated with our comprehensive centers. We see patients from all 50 states. They travel to see us historically, and we have about 4,300 stakeholders throughout our entire network. We see all adult cancer patients, and we're effectively the largest providers of cancer care in the nation. We have several, 325,000 inquiries per year in terms of the care that we're providing. We take the patient satisfaction very seriously, and we're ranked the 99th percentile on patient satisfaction. In 2018, we were ranked #1 US healthcare brand. We have a robust multidisciplinary precision medicine program, and we see very complex cancer. So hopefully that provides a bit of a setting for you all in what we are doing. So how has COVID changed the outlook for telehealth? I think Sophia has spoken about this as well, and it has changed telehealth in a number of ways. So one, from a consumer standpoint, you can see, and this was from a McKinsey consumer survey, there was a clear shift in telehealth utilization. 11% of consumers had noted that they've utilized telehealth in 2019, and most recently it's up to 76%. There is a shift in the utilization from our providers, where we saw a 50 to 175x increase in the number of telehealth visits compared to pre-COVID state. And then there's a shift in the regulatory standpoint, which Sophia spoke extensively about. So 80 different new services. So we have definitely seen a change. The way we at CTCA are utilizing the telehealth is in a very unique fashion. So initially, we deployed a kind of a phased approach. Our clinical use cases was the early focus. And then we've shifted to a more hybrid model. And more recently, we're extending our services into the home. So for the phase one, we had a bit of a risk mitigation strategy like much of the nation, where in particular for our cancer patients, it was vitally important to remain connected with their care doctors. So in a matter of days, we scaled our program in a pre-COVID state. We had a nascent program in telehealth. And once the pandemic hit and the barriers were removed for its utilization, we have 27 oncology service lines. And to date, we have 33 different oncology service lines utilizing telehealth. Additionally, we have our clinical trials program, which is utilizing telehealth as well. As the pandemic continued, we've shifted to a bridge to on-site care. This is once the facilities opened up, and we've shifted to additional visits as needed to prevent deterioration. You know, it's now provided an ability to monitor symptoms before they escalate, to monitor pain control before it gets unbearable, and decrease emergency room utilization. So there are a lot of effective ways that we look at this hybrid model. And then most recently, we have a Rural Health Coordinated Cancer Care Alliance program that I'll speak about. We started this in a pre-COVID state and continue it throughout. We've utilized the oversight of telehealth and remote patient monitoring in a chemotherapy program for select individuals for select chemotherapy. So it really has provided us with a large opportunity to meet the patient where they are and to provide that added connectivity beyond the brick and mortar. Next slide. This shows a brief, since the 25th, this was published in Becker's Hospital Review on the left. You can see that we had an 80-fold increase very early on in a 4-week period of our telehealth utilization, both in clinical use cases and in research. And this graph depicts that rapid increase. We were able to provide those services with key considerations. We had a program that was set in place and essentially organized a very robust group, multidisciplinary team, multifunctional team, utilizing both clinical and technology. We had a telehealth, what we call concierge team. So these are just kind of key factors that we were able to experience increased utilization and scale and meet the needs of our patients. And today we're well over 18,000 visits and have served, 8,500 patients and counting. In particular, looking at our those participants who are utilizing telehealth for active clinical trials, it's over 40%. So we're certainly able to utilize telehealth in a way that we would not have otherwise, and to meet the needs of our oncology patients. And just to remind you all, it's those oncology patients, those immunosuppressed patients who are most at risk for contracting the illness. And there have been recent studies to suggest that there has an increased mortality rate in immunocompromised individuals as well. So it's certainly been necessary for us to keep our patients safe and to provide them with the care. They're fighting for their lives, and we're able to continue that fight alongside them. Next slide. This is a bit of a description of our Coordinated Cancer Care Alliance program, where the goal of this program is to offer high quality oncology services closer to home. So we partner with rural hospitals in order at our sites in order to provide that care to the patients and in a collaborative fashion. So we're able to expand their patient base of the rural hospitals, increase service utilization, and for the patients, they're really able to get access to that medical oncologist. They're able to get our fast initial diagnosis and treatment plan set in place on a 3-day basis, and speed to care and to treatment with shorter wait times, reduced transportation and cost, and time off of work all highlight the patient benefits. And like I had mentioned, there's certainly benefits with the hospitals that we're collaborating with also. So I will say, if there's certainly interest in continuing the collaboration, please don't hesitate to reach out to us to get the care where it's needed and to provide access to your patients. Next paragraph. Next slide. So our Oncology Clinic at Home program is a program that we have partnered with CVS in a recent press release. And what we are utilizing is providing an integrated care delivery model that allows patients to safely receive chemotherapy treatment in the comfort of their homes. We leverage telehealth, remote patient monitoring, and oncology chemotherapy trained nurses to extend that mother standard of care, is what we call at CTCA, to the home, prioritizing quality and safety in a convenient way for our patients, and that's cost effective. So we are excited to be able to offer that to our patients and utilize this additional safety mechanism to make sure that they're receiving the safety of care. So this is just a brief compilation of CTCA and a number of the telehealth items that we are promoting and that we're really hoping in the tele-oncology space to be able to provide a new type of care delivery model for our patients. Next slide. Some of the strategies, the takeaways for an economic sustainability of telehealth, and Sophia spoke to this as well, is our goal is to have reimbursement parity, licensure across states, ability to electronically prescribe to new patients. All of those need to be sustained beyond a public health emergency, so we can completely realize the advantage that telehealth allows us to have. Leveraging telehealth improves efficiency. We have seen that in satisfaction and productivity. It increases patient loyalty and enabling convenience and access, and allows us to proactively respond to patients who are deteriorating or who have any concerns. So we at CTCA have certainly seen an enormous benefit with utilizing telehealth and extending the care delivery model, rethinking how we deliver care to best meet the needs of our patients. With a compilation of brick and mortar and extension. So thank you again for having me. It's excited to speak to this group and look forward to continuing the conversation.
Thank you very much. No doubt, oncology patients are definitely a patient population that benefit a great deal from utilizing telehealth. So thank you for that information. Moving on, we're going to go to our next speaker, Dr. Nix. Dr. Nix is a pediatric cardiologist and electrophysiologist with experience in digital health, medical device, and remote patient monitoring fields since starting practice at Tufts Medical Center in 2010. Dr. Nix was Chief Medical Officer of Geneticist, a company which created a novel cloud-connected and AI-powered cardiac diagnostics and imaging platform. She has authored a book chapter and articles in applications of AI, in peer-reviewed journals on digital health and wearable technologies, and has spoken on the applications of AI in medicine and the role of wearables in clinical practice. So thank you very much for joining us. Please take it away.
Thank you, everyone, for having me. It's great to be here. And hopefully with this talk, we can have a little bit of fun talking about the future of telehealth and starting to realize its value and as a new starting point for better access to healthcare. So as Bill just mentioned, I have a background in advising and participating in leadership in companies that have a digital medicine focus. Even pre-pandemic, 52% of clinicians were willing to engage with remote patient monitoring tools. And so we'll kind of look at that as a factor in how telehealth can grow from here. So this first slide is really focus on pre-pandemic versus post-pandemic utilization of telehealth. Some of this has been mentioned previously, but in a survey performed between February and April 2019, only 49.2% of survey respondents were willing to use video conferencing. And obviously we think this has jumped up spectacularly by virtue of some of the data we already have. We know that by Q2 2020, telemedicine visits had risen to 35.3% of all primary care encounters, which is a vast increase from Q2 2018 and 2019, and that's IQVIA data. A detail that was also made in this publication, which is a really encouraging piece of data, is that there was proportional adoption among white and Black patients, which certainly is a refreshing statistic given the historical disparities that have been documented with people of color, low income, and the elderly with regards to previous access to telemedicine. And then again, whether it's raw numbers or whether it's claims data, Fair Health obviously has a telehealth regional tracker that looks at month-over-month claims, and there's a vast difference between 2019 and 2020 in terms of private insurer claims data. And one of their points was one of the largest jumps in utilization was for hypertension, which I think is no surprise to most clinicians that see these patients and know that that's a low-hanging fruit for remote care. Next slide. So this is another American Well survey. They've been mentioned a couple of times already during these talks. And I know this is a big list, but this is a willingness to use telehealth by specialty. And there's two particular specialties I wanted to point out, and this is a big list. But if you look at the fourth from the top, you see this remarkable parity between willingness to use and actual use, and that is psychiatry. And both the billing structure, the reimbursement structure, and the essentially the format of telehealth really favored mental health care over the past several years. Compare that to the second from the bottom, which unfortunately is my specialty. That's cardiology. So in 2019, only about 48% of cardiologists were even willing to use it. And you see that there's almost no usage by cardiologists. And I think that really provokes some thought about why. Is it just reimbursement? Or when I think about my colleague the other day who was bemoaning the fact that he was referred a telemedicine visit for a heart murmur, it really does speak to the fact that there are certain specialties who need tools in order to make telehealth a valuable piece of clinical care. Next slide. So here is, with that in mind, here is a graphic that I think many people have seen regarding the sudden use of telemedicine in the first part of the pandemic. And you see this surge of usage in late March through April and into May that actually was truly a result of a shutdown in areas like mine where we didn't have any clinics open, we didn't have any outpatient imaging, and everyone's mammogram got canceled. And we had certainly this kind of curve that really reflected the surge in COVID-19. Once that actually subsided during the summer, this curve actually decreased. And so the question needs to be asked why. Now, it did sustain itself to some degree into the fall. Certainly compared to 2019, there was still a marked increase in utilization compared to the same month the previous year. but still there is a question about sort of why this wasn't sustained at a higher level. The other point about this, curve is that you see that practice size actually did matter. So the larger the practice and the larger the institution, the more resources they had to actually invest in telehealth. And so that's another disparity that we have to think about when we have a discussion about kind of how telehealth can be used in a more effective and more universal way. Next slide. So here are some quality metrics I'll say that play into the feasibility of telehealth. One is the quality of the technology. How accessible is it? Can you use it on multiple different devices? Now, not to hate on Epic, but when I was a patient this past year, my telehealth had to be accessed through the patient portal. And not only that, it could only be accessed on a smartphone or a tablet. Now, for me, that's no problem, but for my 80-year-old parents who can barely text on a smartphone, they can't possibly figure out how to download an app and access that type of telehealth. That's a problem, and we have to kind of think about sort of how we're leveraging this technology to make sure that we get to the patients who need it. So number two, I think this is going to be a real concern. I anticipate a lot of questions about this. There are definitely think tanks out there that are looking at reimbursement in the future. And I think there's hopefulness about kind of making these changes permanent. But there are going to be certain audits that are going to influence the current reimbursement status in the future. And telemedicine needs to continue to be substitutive, not additive. So, we have a situation where there have been predictions that telehealth could become more expensive than in-person care. And we need to continue to work towards a state where that doesn't become the case. Otherwise, it economically is not feasible anymore. Number three, I think as a physician, digital burnout prevention is really important. You need physician buy-in. If you're getting a lot of different data from patients that needs to be integrated into one unified platform, it's really hard to look at 4 different portals and integrate that information and be able to kind of continue on your day without totally, losing your mind. So that's a really practical part of this picture. And then finally, clinical data enrichment. And that's where we get to remote patient monitoring tools and how we can actually use telemedicine in a very valuable way, which makes it substitutive and not additive. Next slide. So here's our wheel of digital medicine. And this is sort of the array of tools that we can use. And obviously at 12 o'clock and 6 o'clock here, we have kind of the most common devices, home blood pressure cuffs and glucose monitoring tools and glucometers. Then, I couldn't even, there's not even room for a couple of others like digital scales, otoscopes, lots of different things that we can use. And you can see from this array that there are things that you can use to formulate a package for certain chronic disease management. For instance, a pulse oximeter and a spirometer for a COPD patient, or a mobile ECG, a digital stethoscope, and a blood pressure cuff, and a scale for congestive heart failure. So there are definitely packages that you can sort of see can augment the use of just video visits to people in front of a screen talking to each other. I did add the price tags on these devices though, and that was by design, because if you look at the prices of some of these tools, you can see that this adds up. And probably if we're asking patients to buy these or purchase these on their own dime, you're really committing them to spend probably about $150 to $200 on average. And for a lot of folks right now who are trying to figure out whether they can afford food versus their prescription medication, we have to think about, is this feasible, and how we balance what we want from telemedicine from what patients can actually afford to help us with. Next slide. So Sophia brought this up, the CARES Act and the FCC's $200 million telehealth grant program. And this actually happened where several health systems actually applied for grants, got grants, and actually invested in purchasing and giving out remote patient monitoring tools to their patients. And this really was a function of the COVID-19 pandemic, where high-risk patients were sent home with this to monitor their progress, make sure there was not an exacerbation of their symptoms. And the Mayo Clinic in particular, they did get some grant money, but they also did fund some of this through their own resources. And they really did, publish some data that looked at patients who had remote patient monitoring tools at home, and they did have better outcomes in terms of their survival and morbidity. Next slide. So remote patient monitoring is really fun to think about. There's some really amazing things out there, and Dr. Dave will talk about his tool. And you can see that in the long term, telehealth, especially for broader use across multiple specialties, really needs to be enriched with some exam potential, some way of testing patients that is objective data. And we don't have a lot of that right now. We hope to have that, and we think that it's increasing. But the big burden here is financial. So again, we have the choices here. The individual investments, where the burden of cost is falling on the patient. There's also an additional challenge when an individual physician says, hey, I think it'd be great if you have this device at home. That is great, but it's up to that physician to kind of, manage the back end, the management of that data. And without institutional support, that becomes a huge obstacle to doing that at scale. Number two is enterprise investment. So that's where healthcare systems like the Mayo Clinic invest in a package of remote patient monitoring solutions for their high-risk patients. And this does not rule out some investment by third parties, whether it's a payer and a combination of all three of these. But the third-party partnerships involve telehealth companies. So at some point, telehealth software companies need to actually think about whether they are interested in investing in their own suite of tools to distribute to patients. We're already investing in hospital at home. We have private companies who are actually selling services to provide hospital at home. And so this is a very feasible expectation that could actually lend a hand to some of these other options which have their limitations. So that's something to think about. I think that we have a lot that is possible for telehealth and enriching these solutions with devices at home that patients can easily use and access to be more engaged in their own care.
All right, thank you very much. Great information. As you mentioned, the clinical metrics, capturing those clinical metrics is very important when growing or looking to grow your telehealth program. Without it, you're not going to be able to determine whether you're successful or not. So thank you very much for the information. I'm sure we'll get a lot of questions. All right, jumping right into our next presenter, we have Dr. Albert. Dr. Albert is from Oklahoma, and he is a physician, inventor, and serial entrepreneur who has developed life-saving technologies and products over the last 30 years. Today, he is a founder of three technology.
I'm really old.
Today, he is a founder of three technology companies, Innov Alarm, LifeTone Technology, and AliveCore. His latest invention, AliveCore's Cardio Mobile Personal ECG technology, became a global sensation. So please join me in welcoming Dr. Albert. Take it away.
Thank you very much. Next slide, please. You don't need to know about me. Keep going. Next slide. AliveCore is an arms dealer. Now, I mean that in a very nice way. That is, we enable Telecare and have been doing so for almost 10 years. And obviously, in the last year, as the previous speakers have said, there's been a dramatic increase in the utilization of remote care. But we've been doing it for quite a long time. And I can tell you, we were a beneficiary. So as it was a challenge for all of us, and I can tell you that my wife is a faculty member in rheumatology at LA County. Because of the pandemic, she just did 2 nights in a row as a nocturnist at LA County Hospital. My oldest son is the co-lead of COVID at Cedars-Sinai, the biggest hospital in California. So I can tell you, I have a lot of COVID experience. I've had 1 shot, by the way. I'm waiting for my second one. And I can tell you it has made a major change in the area that we deal with, and that is remote cardiovascular care, as Elisa said. So what I want to talk about is how we've dealt with this, how our customers have dealt with this, and what do I see for the future? Next slide, please. So over the last year, we grew almost 100%. And millions of ECGs every month come into our cloud and can be transmitted directly. And this, while this is not new, for instance, Cleveland Clinic, every AFib ablation patient at Cleveland Clinic gets an AliveCore. Why? Because their patients come from all over the world. They can't just hop on their private jet and fly into Cleveland for a follow-up visit. So this has been utilized. Telemedicine, remote ECG monitoring has been utilized. And by the way, I'm proud to say that on Elisa's slide, we were the $89 remote ECG, okay? So we're the low-cost provider, and that's really important to us because we need to be able to provide this globally, and we provide it in 37 countries. So it's not just the United States. Telemedicine, we have a huge healthcare infrastructure in the US, but a lot of places, kind of like they didn't have wired telephone service or wired, cable TV, wireless and telehealth became the only way they can provide across their population. So next slide. So what did we do? Well, we were almost immediately, as everyone may remember, there was a flurry of interest in true drugs, hydroxychloroquine, known as Plaquenil. My wife, as a rheumatologist, uses it all the time. And another one, azithromycin. You may have had a Z-Pak, a common antibiotic. Well, those drugs were thought to be of use. The only problem is both of those drugs are what we call a QT prolonger. And there were a flurry of studies. We were involved in a number of studies because if you happen to have congenitally a long QT interval, which is a measurement we in cardiology do to assess your risk of developing a serious, potentially fatal event, and you got those 2 medications and you had a fever, you could die. And people, unfortunately, were some of them were getting these medicines and taking them, I would say, through the gray market. So we received an emergency use authorization to have our latest device, which actually provides half of the 12-lead ECG. It's our Cardia 6L, to use it for QT measurement. which it was not previously FDA cleared for. So it actually got used all over the world. And the interesting thing is, you would think, well, that's great if these patients are at home and they're taking this, make sure they're safe. It was used in hospitals. Why? Because COVID in hospitals, we've all, people hopefully watched the news about what happened in New York back in the spring, what's been happening over the last month or so here in Los Angeles, where I live today, because I have a brand new granddaughter. And so what happened is that we normally roll around EC carts and go in and attach electrodes and do all that. Well, when you're in a COVID unit, any, PPE became important. These EKG technicians we have in hospitals were not that interested. And also, by the way, their equipment's not that easy to clean. So all of a sudden, our devices were used in hospitals to do this monitoring of rhythm in these patients. And as Elisa can tell you, we still had cardiology patients. We still had oncology patients. And so another thing that happened is our device began to be used for oncology patients. You may have seen an ad for a drug called Kisqali, which is a Novartis drug used for breast cancer. It too causes QT prolongation. So now all of a sudden, when you had patients who couldn't come in, who couldn't visit hospitals, because by the way, they might be immune compromised, and they were high risk, our technology found an immediate new use. And so we were very fortunate that we could help solve a problem clinically. And then there just became the increased utilization of telehealth. If you're doing a follow-up visit, normally you'd have a patient come in, you do an electrocardiogram, a normal one, you talk to the patient, you might listen to their heart. And that became something that may have been risky because, by the way, in adult cardiology, as opposed to Elisa's pediatric cardiology population, we have a lot of elderly people. It's a Medicare population by and large. I can tell you at AliveCor, between 60 and 80 is our biggest group of patients. So these are people who we now know are at high risk. And so being able to monitor them for a follow-up visit using a tele-ECG, a tele-rhythm strip, and a video call became very commonplace, not just for the Cleveland clinics and the Mayo clinics, but for practices of all size. So this has been, I would say we're interested in finding out, and I can tell you, we're all talking about, well, will the exclusion and the new rules for telehealth reimbursement last beyond the pandemic? I can tell you, having family on the front lines, a year from now, we'll still be at some level in the pandemic, okay? This is a tough virus, as everybody's heard. It keeps mutating. And I would tell you that we will still be wearing masks in many situations. We'll still be pushing patients to televisits when it's appropriate. And by the way, you saw cardiology. While in the future, with companies like Butterfly, we may have home echocardiograms. We may. Today, it's not practical. So we can't do MRI scans. We can't do stress tests. So those kinds of technologies. And what I was really surprised at is that cardiologists used less telemedicine than radiologists. I don't know what radiologists were doing in telemedicine. So I'm still pretty, I'm interested in finding out. So what I would say is, next slide. We see medicine. We've talked about providers. Patients love telemedicine. They love it, not just because they maybe feel safer, but it's more convenient. You don't have to park. You don't have to wait in a waiting room. There are all kinds of issues that we often as providers don't take into consideration. And so I think there will be a lot of pressure, certainly the economic pressure that Lisa talked about and other people talked about in terms of reimbursement, but there will be a lot of pressure from patients. And as my good friend Eric Topol says, the patient will see you now and the patient will see you over Zoom. And I think that is an inevitable part of the future of healthcare. So next slide. So I just wanted to say thank you for inviting me to South Florida HIMSS. And I look forward to any questions. And I look forward to seeing what the future brings us in terms of delivering telemedical care and healthcare in general. Thank you.
All right, thank you very much. A lot of great information, as all of you heard. We did get a few questions. We got 3 minutes left before our meeting ends. So I wanted to just get a few of these questions in here. It was asked, which metrics are relevant in telehealth today that are not captured, that were not captured pre-COVID? I open that to anyone. So anyone from the panel, if you can answer that.
I'm not exactly sure what that means. So that unfortunately, what metrics are captured today? I mean, utilization metrics, quality of care metrics, patient satisfaction metrics. I'm not sure. You know, all those are now, everybody looks at their health grades. Everybody looks at their patient satisfaction. In fact, in many major health systems, patient satisfaction is one of your pay metrics. So I'm not exactly sure if that's what was meant by the.
And I would add to that, perhaps a metric that has not been looked at that could certainly be looked at more is education, consumers and physicians' understanding of telehealth platforms and technology, because it was so rapid having to immobilize telehealth services. It's an area that really should be looked at to see, are they understanding how to utilize those services, and what do organizations need to do in order to improve their education efforts to get their consumers to understand how to utilize the tools available to them.
I would also add just scale. I mean, we're just using so many more tools like virtually, and you know, the telehealth literature out there, you know, has like small case reports or, you know, small cohorts. You know, now we can actually kind of look at thousands and thousands of patients, you know, whether it's COVID-19 we're focused on, but I think it's just a matter of actually publishing things about patient outcomes at a larger scale.
Yeah, and I'd like to add something that we didn't really notice before telehealth, but the bottlenecks that we had, the technology issues that we had, the bandwidth issues that we had, all of that those weren't metrics that were captured before because we didn't have issues before. Now that we've seen those issues, they're definitely metrics that we want to capture, and we'll probably see many, many more to come. It's 1 o'clock. I'm sorry we didn't get to all the questions. We'll try to include them. Kendall, would you like to close us out?
Yeah, that sounds good. Thank you, everyone that was on the panelist, and Bill for moderating. Again, we look forward to seeing everyone that joined us today again on future webinars. We appreciate your support with South Florida HIMSS, and we encourage membership. So reach out if you want to learn more about South Florida HIMSS, and thank you again, panelists. Have a nice day.
Thank you, everyone.